at the COSTEM, we have this interesting strategy that is always a pro and con, and I was assigned to argue that there should be no preference of a defined CD19 CAR T-cell product in relapsed refractory DLBCL. And within my argument, I made 4 points. So first of all, we have very different constructs. So we have a different starting material, we have a different vector, but I think what's also important to acknowledge is we also have different lymphodepleting regimens. So we have different doses of fludarabine and cyclophosphamide, and that comes particularly evident if you look at the lymphodepleting regimen of Tizacel or Tezacel, because it differs between the B-cell precursor ALL setting and the large B-cell lymphoma setting. And importantly, it has been shown that with the higher dose, which is applied in the ALL setting, you have a larger CAR T-cell expansion, and it seems to be that the fludarabine dose is highly relevant, because it was shown that the area under the curve of fludarabine correlates to CAR T-cell expansion and also to outcomes. So just to clarify, we really have different products, and the lymphodepleting is contributing to this. So then there's other evidence, that's my second point, where disease and patient characteristics have been shown to have a high impact on outcome. And that has been shown in the case of Axi-cel and Tezacel. And for these 2 products, we have most evidence also from the real world setting. And has been shown that, for example, patient characteristics like ECOG or pro-inflammatory markers like CRP and ferritin, independent of the product, are predictive biomarkers for outcome. And it also applies to disease characteristics, for example, metabolic tumor volume as well as LDH, arguing that sort of the road to whatever treatment outcome is more important than the CAR we are actually using. And the third point is the new sort of clinical trial setting is propensity match scoring. So there has been a publication by the French group from over 600 patients comparing relapsed refractory DLBCL treated with either Tezacel or Axi-cel, and they've done a very thorough job of what kind of parameters they integrated into the propensity match scoring, and they could show that if you look at overall response rate as well as complete remission rate, Axi-cel was superior to Tezacel. However, duration of response then was not significantly different. But I'm arguing that not all parameters that are relevant were actually integrated, and the propensity match scoring is only as good as the parameters you integrate. And for example, parameters that have been shown to be highly significant, comorbidities, but also markers of inflammation like ferritin, were not included in this. So I don't think that this is the answer, and it cannot substitute for randomized clinical trials which are missing for the CAR T-cell products. And last, maybe, I think the truth, as always, is that we have to go for a more individualized approach. So we have to identify which biomarkers are most relevant for each individual patient and which product is most suitable, also considering that the toxicity profile of the different constructs is quite different. And as everybody is aware, we have a high incidence of neurotoxicity with Axi-cel that is not seen with Tezacel and also with Liso-cel. So I think it also has to be taken into account what is the price we are paying. Clearly, in large B-cell lymphoma, we are aiming for cure, so toxicity can be accepted to some extent, but this has to be taken into balance.